Guillain-Barré syndrome is a rare but potentially fatal immune-mediated disease of the peripheral nerves and nerve roots. It is the most common cause of acute or subacute generalized paralysis in practice. GBS occurs more frequently in males than in females, and the incidence increases with age, although all age groups can be affected. The most common variant is acute inflammatory demyelinating polyneuropathy. Etiology: GBS and its variants are considered post-infectious immune-mediated neuropathies. A mild respiratory or gastrointestinal infection or immunization precedes the neuropathic symptoms by 1 to 3 weeks in approximately 60% of cases. Campylobacter jejuni is the most frequent identifiable antecedent infection. Others are cytomegalovirus, Epstein-Barr virus, HIV, and less often bacterial infections other than Campylobacter such as Mycoplasma pneumoniae, Lyme disease. Molecular mimicry is the structural, functional, or immunological similarities shared between macromolecules found on infectious pathogens and in host tissues. Normally, the body is tolerant to self-antigens which are present in individual tissues. When a foreign antigen shares sequence or structural similarities with self-antigens, tolerance is abrogated to self-antigens and tissues or organs are destroyed by the immune system. Therefore, molecular mimicry of a self-antigen by an infectious pathogen such as bacteria and viruses may trigger autoimmune disease due to a cross-reactive immune response against the infection. Pathophysiology: molecular mimicry plays a substantial role in GBS, particularly the axonal variant. The lipo-oligosaccharide of Campylobacter jejuni is similar to the gangliosides of peripheral nerve membranes. Therefore, an immune response triggered to fight infection can lead to a cross-reaction on host nerves. Antibodies: ganglioside antibodies have been shown to have different peripheral nerve targets, such as anti-GD1A antibodies bind to a paranodal myelin, nodes of Ranvier, and neuromuscular junction. GM1 and GQ1B antibodies bind to a peripheral nerve or neuromuscular junction. These different peripheral nerve targets may play a role in the heterogeneity of the clinical presentation of GBS. Certain gangliosides are more likely to be associated with specific presentations. For example, Miller-Fisher syndrome is associated with the anti-GQ1B antibody. The axonal motor neuropathy form may be associated with anti-GM1 antibodies. The pharyngeal cervical brachial variant of GBS may be associated with anti-GT1A antibodies. Now, important clinical notes. Guillain-Barré syndrome patients describe a fulminant course of symptoms that usually include ascending weakness and non-length dependent sensory symptoms. By definition, the nadir is usually reached within 4 weeks. Symmetric involvement is a key feature of Guillain-Barré syndrome. It is usually considered monophasic. Therefore, a relapsing or remitting course at presentation would be considered atypical. Additionally, a prior GBS event or recurrent GBS is also unusual, occurring in less than 10% of all patients. If the patient reports progression beyond 8 weeks, other diagnoses should be considered. Typical clinical features. Guillain-Barré syndrome should be considered as a diagnosis in patients who have rapidly progressive bilateral weakness of the legs and/or arms in the absence of central nervous system involvement or other obvious causes. Patients with the classic sensory-motor form of Guillain-Barré syndrome present with distal paresthesias or sensory loss, accompanied or followed by weakness that starts in the legs and progresses to the arms and cranial muscles. Reflexes are decreased or absent in most patients at presentation and in almost all patients at nadir. Dysautonomia is common and can include blood pressure or heart rate instability, pupillary dysfunction, and bowel or bladder dysfunction. Patients can develop facial diplegia due to the involvement of both facial cranial nerves. They can also develop dysphagia due to the involvement of the glossopharyngeal, vagus, and hypoglossal cranial nerves. Pain is frequently reported and can be muscular, radicular, or neuropathic. Disease onset is acute or subacute, and patients typically reach maximum disability within 2 weeks. Additionally, the involvement of the lower cranial nerves, such as glossopharyngeal, vagus, and hypoglossal nerves, or involvement of the nerves to the muscles of respiration may lead to need for artificial ventilation. Respiratory failure can occur in up to 30% of patients, usually leading to prolonged hospitalization and recovery. Variants. Some patients have a distinct and persistent clinical variant of Guillain-Barré syndrome that does not progress to the classic pattern of sensory loss and weakness. In pure motor variant, there is motor weakness without sensory signs. In paraplegic variant, there is paresis restricted to the legs. In pharyngeal cervical brachial variant, there is weakness of pharyngeal, cervical, and brachial muscles without lower limb weakness. In bilateral facial palsy with paresthesias, there are bilateral facial weakness, paresthesias, and reduced reflexes. In pure sensory variant, there is acute or subacute sensory neuropathy without other deficits. Miller-Fisher syndrome is a triad of ophthalmoplegia, ataxia, and areflexia. In Bickerstaff brainstem encephalitis, there are ophthalmoplegia, ataxia, areflexia, pyramidal tract signs, and impaired consciousness. Now, diagnostic criteria. Features that are required for diagnosis are progressive bilateral weakness of arms and legs. Initially, only legs may be involved. Absent or decreased tendon reflexes in affected limbs at some point in clinical course. Features that strongly support diagnosis. Progressive phase lasts from days to 4 weeks, usually less than 2 weeks. Relative symmetry of symptoms and signs. Relatively mild sensory symptoms and signs which are absent in pure motor variant. Cranial nerve involvement, especially bilateral facial palsy. Autonomic dysfunction. Muscular or radicular back or limb pain. Increased protein level in cerebrospinal fluid, but normal protein levels do not rule out diagnosis. Electrodiagnostic features of motor or sensorimotor neuropathy, but normal electrophysiology in the early stages does not rule out the diagnosis. Features that cast doubt on diagnosis. Increased numbers of mononuclear or polymorphonuclear cells in cerebrospinal fluid. Marked persistent asymmetry of weakness, bladder or bowel dysfunction at onset or persistent during disease course, severe respiratory dysfunction with limited limb weakness at onset, sensory signs with limited weakness at onset, fever at onset, nadir less than 24 hours. Also, sharp sensory level indicating spinal cord injury, hyperreflexia or clonus, extensor plantar responses, abdominal pain, slow progression with limited weakness without respiratory involvement, continued progression for more than 4 weeks after start of symptoms, alteration of consciousness, except in Bickerstaff brainstem encephalitis. The differential diagnosis of progressive paralysis is relatively wide early in the syndrome, the initial focus being on locating the pathology in the nerve roots and peripheral nerves rather than elsewhere in the nervous system. When a diagnosis of a neuropathy has been made, the differential diagnosis includes infections such as Lyme, diphtheria, inflammatory such as neurosarcoid, paraneoplastic, malignant due to infiltration of nerve roots, vasculitic, metabolic such as beriberi due to vitamin B1 deficiency. Evaluation. Guillain-Barré syndrome is considered a clinical diagnosis. Therefore, a diagnosis can be made with confidence at the bedside in most cases. Electromyography and nerve conduction studies may be helpful in distinguishing Guillain-Barré syndrome from its mimics. Nerve conduction studies utilize technology to help distinguish between demyelinating and axonal forms of neuropathy. Classically, electrodiagnostic studies should be undertaken at 10 to 14 days after symptom onset due to the time for Wallerian degeneration of sensory and motor nerve fibers. Cerebrospinal fluid shows a classic pattern of albuminocytologic dissociation. This term means that spinal fluid shows a normal amount of white blood cells and an elevated protein level. However, this pattern is only present in 80% of patients at 2 weeks following symptom onset. Therefore, the absence of this classic finding does not exclude the diagnosis. If the white blood cell count is elevated, this should prompt consideration of other infectious GBS mimics such as HIV seroconversion. A number of ganglioside antibodies have been associated with Guillain-Barré syndrome. Antibodies include anti-GM1, anti-GD1A, anti-GT1A, and anti-GQ1B. These range in sensitivity from up to 60% in case of anti-GM1 antibodies in acute motor axonal neuropathy to up to more than 90% in case of anti-GQ1B antibodies in Miller-Fisher syndrome. However, these laboratory studies usually require some time to obtain results and therefore may not be as helpful in decision making at the time of patient admission. Imaging studies such as MRI of the spine may show enhancement of the nerve roots, indicating a breakdown of the blood-nerve barrier due to inflammation in Guillain-Barré syndrome. However, MRI utility in GBS is most useful to rule out other etiologies of quadriparesis or facial diplegia, such as transverse myelitis or intracranial disease. This contrast enhanced fat suppressed sagittal T1 weighted MRI shows marked contrast enhancement of thickened nerve roots of cauda equina and conus medullaris. A negative inspiratory force with a respiratory pressure meter should be performed on patients with suspected Guillain-Barré syndrome. Serial negative inspiratory force should be followed in patients with a high risk of respiratory compromise. Now the treatment of Guillain-Barré syndrome. Intravenous immunoglobulin 0.4 gram per kg body weight daily for 5 days and plasma exchange 200 to 250 ml plasma per kg body weight in 5 sessions are equally effective treatments for Guillain-Barré syndrome. IVIG and plasma exchange carry comparable risks of adverse events, although early studies showed that plasma exchange was more likely than IVIG to be discontinued. As IVIG is also easier to administer and generally more widely available than plasma exchange, it is usually the treatment of choice. Besides IVIG and plasma exchange, no other procedures or drugs have been proven effective in the treatment of Guillain-Barré syndrome. Plasma exchange followed by IVIG is no more effective than either treatment alone. Although corticosteroids would be expected to be beneficial in reducing inflammation and therefore disease progression in Guillain-Barré syndrome, 8 randomized controlled trials on the efficacy of corticosteroids for Guillain-Barré syndrome showed no significant benefit, and treatment with oral corticosteroids was even shown to have a negative effect on outcome. In clinical settings where resources are limited, small volume plasma exchange might be an economical and relatively safe alternative to conventional plasma exchange, but this approach cannot be recommended for general use until its efficacy has been established in further trials. Now, the treatment for GBS variants. First, Miller-Fisher syndrome. Patients with pure Miller-Fisher syndrome tend to have a relatively mild disease course, and most recover completely without treatment within 6 months. Therefore, treatment is generally not recommended in this patient group, but patients should be monitored closely because a subgroup can develop limb weakness, bulbar or facial palsy, or respiratory failure. Next, Bickerstaff brainstem encephalitis. The severity of this disease justifies treatment with IVIG or plasma exchange, although evidence for the efficacy of treatment in this context is limited. For other clinical variants, no evidence regarding treatment is currently available, although many experts will administer IVIG or plasma exchange. Next, pregnant women. Neither IVIG nor plasma exchange is contraindicated during pregnancy. However, as plasma exchange requires additional considerations and monitoring, IVIG might be preferred. Next, children. There is no indication that it is necessary to deviate from standard adult practice when treating children with Guillain-Barré syndrome, as plasma exchange is only available in centers that are experienced with its use and seems to produce greater discomfort and higher rates of complications than IVIG in children. IVIG is usually the first-line therapy for children with GBS. Monitoring disease progression. Routine measurement of respiratory function is advised, as not all patients with respiratory insufficiency will have clinical signs of dyspnea. Muscle strength in the neck, arms, and legs should be assessed. Patients should be monitored for swallowing and coughing difficulties. Autonomic dysfunction should be assessed via electrocardiography, and monitoring of heart rate, blood pressure, and bowel and bladder function. The nature and frequency of monitoring depends on the rate of deterioration, the presence or absence of autonomic dysfunction, the phase of the disease, and the healthcare setting, and should be carefully assessed in each individual patient. Up to two-thirds of the deaths of patients with Guillain-Barré syndrome occur during the recovery phase and are mostly caused by cardiovascular and respiratory dysfunction. Therefore, clinicians are advised to stay alert during this phase and monitor the patient for potential arrhythmias, blood pressure shifts, or respiratory distress caused by mucus plugs. This monitoring is especially important in patients who have recently left the ICU and in those with cardiovascular risk factors. Managing early complications. Pressure ulcers, hospital-acquired infections, for example pneumonia or urinary tract infections, and deep vein thrombosis can occur in any hospitalized bedbound patient, and standard practice preventive measures and treatment are recommended. Other complications are more specific to Guillain-Barré syndrome, for example, the inability to swallow safely in patients with bulbar palsy, corneal ulceration in patients with facial palsy, and limb contractures, ossification, and pressure palsies in patients with limb weakness. Pain, hallucinations, anxiety, and depression are also frequent in patients with Guillain-Barré syndrome, and caregivers should specifically ask patients whether they are experiencing these symptoms, especially if patients have limited communication abilities and/or are in the ICU. Adequate management of complications is best undertaken by a multidisciplinary team, which might include nurses, physiotherapists, rehabilitation specialists, occupational therapists, speech therapists, and dietitians. Insufficient response to treatment. About 40% of patients treated with standard doses of plasma exchange or IVIG do not improve in the first 4 weeks following treatment. Such disease progression does not imply that the treatment is ineffective, as progression might have been worse without therapy. Clinicians may consider repeating the treatment or changing to an alternate treatment, but at present no evidence exists that this approach will improve the outcome. A clinical trial investigating the effect of administering a second IVIG dose is ongoing. Treatment-related fluctuations are observed in 6 to 10% of patients with Guillain-Barré syndrome and are defined as disease progression occurring within 2 months following an initial treatment-induced clinical improvement or stabilization. It should be distinguished from clinical progression without any initial response to treatment. The general view is that a treatment-related fluctuation indicates that the treatment effect has worn off while the inflammatory phase of the disease is still ongoing. Therefore, patients with Guillain-Barré syndrome who display treatment-related fluctuations might benefit from further treatment, and repeating the full course of IVIG or plasma exchange in these patients is a common practice, although evidence to support this approach is lacking. Now, planning rehabilitation. Patients with Guillain-Barré syndrome can experience a range of long-term residual problems, including incomplete recovery of motor and sensory function, as well as fatigue, pain, and psychological distress. Before the patient is discharged, these possible long-term effects of Guillain-Barré syndrome should be considered and managed. Physical function. Arranging a rehabilitation program with a rehabilitation specialist, physiotherapist, and occupational therapist is a crucial step towards recovery. Programs should aim to reduce disability in the early stages of recovery and later to restore motor and sensory function and physical condition to pre-disease levels. Exercise programs for patients with Guillain-Barré syndrome, which include range of motion exercises, stationary cycling, walking, and strength training, have been shown to improve physical fitness, walking ability, and independence in activities of daily living. However, the intensity of the exercise must be closely monitored, as overwork can cause fatigue. Fatigue, unrelated to residual motor deficits, is found in 60 to 80% of patients with Guillain-Barré syndrome and is often one of the most disabling complaints. Other causes should be considered before concluding that fatigue in a patient is a residual result of Guillain-Barré syndrome. As with recovery of physical function, a graded supervised exercise program has been shown to be useful in reducing fatigue. Severe pain is reported in at least one-third of patients with Guillain-Barré syndrome 1 year after disease onset and can persist for more than 10 years. Chronic pain in Guillain-Barré syndrome is characterized by muscle pain in the lower back and limbs, painful paresthesias, arthralgia, and radicular pain. Although the pathogenesis of this pain is not fully understood, muscle pain and arthralgia might be attributable to immobility, and neuropathic pain might be caused by regeneration of or persistent damage to small nerve fibers. Management strategies include encouraging mobilization and administering drugs for neuropathic or nociceptive pain. Psychological distress. Rapid loss of physical function, often in previously healthy individuals, can be severely traumatic and may cause anxiety and/or depression. Early recognition and management of psychological distress is important in patients with Guillain-Barré syndrome, especially as mental status can influence physical recovery and vice versa. Referral to a psychologist or psychiatrist might be beneficial for some patients. Providing accurate information to patients on the relatively good chance of recovery and low recurrence risk can help reduce their fear. Connecting patients with others who have had Guillain-Barré syndrome can also help guide them through the rehabilitation process.